Oh, all right. It's 12:30, so we're going to go ahead and get started. Um, all right, so thank you for joining us today for our South Texas Regional Family Medicine Grand Rounds. Our educational partner today is the South Central Area Health Education Center, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. All right, today is March 19th, 2025, and you can claim CME credit via the CME credit via text system by texting the code on the screen, text to 10-1009-6250 to the number on the screen. You must register for each session by midnight to receive credit. WFP members can use your WFP login and claim credit for this activity online at the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the WAFP, and physicians should claim only the credit commensurate with their extent of their participation in the activity. Our Grand Rounds address the following nationally established vision core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. All right, and now Dr. Nato will introduce our speakers.
All right. So I'll introduce both speakers. Dr. Vanessa Sanchez is going to speak first. So Dr. Vanessa Sanchez is a native of South Texas, having grown up and been raised in McAllen, Texas. She acquired her undergraduate degree and her medical degrees from the University of Texas, Rio Grande Valley. She now considers San Antonio to be her home, and she plans to practice outpatient primary care in the area. She strives to encourage her patients to empower themselves to take ownership of their health. In her free time, she enjoys spending time with her family, including her 3 rescue dogs. Dr. Marianne Padolina was born in the Philippines and grew up in Austin, Texas. She is a Texas Longhorn. She attended University of Texas, Austin, where she received her bachelor's degree in biology before continuing her education at UNT Health Science Center in Fort Worth. There, she obtained her master's degree in medical science. Afterwards, she earned a medical degree at Arkansas College of Osteopathic Medicine. She is currently a family medicine resident at UT Health San Antonio. After residency, Dr. Padolina will be working at an outpatient primary care practice in San Antonio with the University of Medicine Associates.
Thank you, Dr. Nato, for our introductions. My name is Vanessa Sanchez. I'm one of the PGY3 residents. I'm also one of the administrative chief residents for this year here at the UT Health San Antonio Family and Community Medicine Residency. And I will be doing my poem today on amoxicillin oral challenge is safe and accessible for removing erroneous penicillin allergy labels. And I would like to begin by asking the audience, how many of y'all have seen a penicillin allergy on a patient chart? Everybody, 100% of people, including myself. So it's very common, right? It's actually the most commonly reported drug allergy. And how many times has it affected treatment choice for you all? Yes, a lot. So I think that kind of highlights the importance of this. So the objectives here are to explain the issues with incorrect medication allergy labels, to outline what an oral provocation challenge is, and to encourage logical and sensible antibiotic stewardship. So the prevalence of penicillin allergies, according to one of the practice parameters from the American Association of Allergies and Immunologists in 2010, they state that about 10% of patients, so patients everywhere, report having a penicillin allergy, but after doing a complete evaluation, up to 90% of these individuals are actually able to tolerate penicillins. And then according to their most updated practice parameter guideline, adults with histories of distant and benign cutaneous reactions can actually be considered for direct amoxicillin challenge without needing skin testing. So what exactly is an oral provocation challenge, or OPC, as you're going to see abbreviated here in my presentation? It's the administration of a potential allergen via the oral route and with subsequent observation of patients afterwards. So the way it actually works is you recruit the ideal patient for this, which is going to be a patient with a history of like a very, very mild reaction, or maybe a patient who says, well, I think I've been told I have an allergy, but I've never actually had one. So a low risk patient, you're gonna, conduct this in a clinical setting. So it has to be like in a practice. You're gonna have practitioners, so like a physician or an APP, basically give a dose of this potential allergen or medication to the patient and observe them. And the way it works is actually in a multi-step approach. You're going to actually give essentially a test dose of this medication to the patient, observe them for a set amount of time. This amount of time is not set in stone. It can be whatever you think is appropriate, 30 minutes to an hour, let's say. If they don't have a reaction to it, if they tolerated it well, then you're going to give them a higher dose of that medication. And you're essentially going to, observe them after. You're essentially going to do this until you reach the actual target dose you're trying to give your patient. So this might be giving them a test dose, observing, and then giving them the rest of the dose, or potentially giving them a few rounds of extra doses to eventually total the amount that you want to give them. After each time, you're going to observe them. And you are also ideally going to ask the patient to report to you any delayed reactions as well. And then after that, you'll kind of look at the data, interpret it, and decide whether you think that your patient actually had a reaction, or maybe they didn't have a reaction. And then you can potentially consider removing this allergy if you don't think it's a true allergy. So who can perform this oral provocation challenge? So allergists, obviously. According to the American Academy of Allergy, Asthma, and Immunology, there are about 7,100 allergists and immunologists across the US, Canada, and 72 other countries. That's, across a large portion of the world, only about 7,100. According to a study published in the Annals of Allergy, Asthma, and Immunology in 2019, there are about 1.08 allergists and immunologists per 100,000 people. And this has high variability depending on geographic location. And they actually found that they're more densely populated in higher income areas. So you can see that there's kind of very wide variability here. So I just did a quick Google search. How many allergists do we have here in San Antonio? The best number I could find is 54. So if y'all can imagine 54 allergists for, the San Antonio population of over 1 million people. I didn't do the math, but the number is going to be very, very small. PCPs can also perform oral provocation challenges, and that's actually who performed it in the study I'm going to be talking about. So penicillins, I guess just a quick question. Who can someone name some infections that penicillin or penicillins are like first-line treatment for? Yeah, syphilis, exactly. Or a similar type of penicillin, strep throat, amoxicillin, exactly, ear infections. Yes, the high dose amoxicillin. So what are penicillins? They're beta-lactam antibiotics, and they're bactericidal, which going back to, medical school days in pharmacokinetics, bactericidal means that they kill the bacteria completely compared to bacteriostatic, where they just prevent the replication. And the way that penicillin works is it specifically binds to the penicillin binding protein that inhibits the transpeptidase in the peptidoglycan cell wall so that it stops the cross-linking. And I kind of just, put a diagram there. It's a little bit more in details with like the codons and things like that, but it essentially stops that, and that's how it, kills the bacteria. So actually, let me go back. No, that's okay. So types of penicillins, there are a whole bunch of them. So we have the natural penicillins, when you think of penicillin, Pen G, Pen V, right? The difference being the route of administration. You have aminopenicillins like ampicillin. You have ampicillin sulbactam, otherwise known as unison. You have amoxicillin clavulanate, which is augmentin. Then you also have penicillinase-resistant penicillins, being like dicloxacin, nafcillin, oxacillin. And then everyone's favorite, right, that we see on IPS all the time, the broad spectrum or anti-pseudomonal penicillin, piperacillin, tazobactam, or Zosyn. Um, does anyone happen to know, and it's okay if you don't, any other types of like beta-lactam antibiotics? Cephalosporins are beta-lactams. So cephalosporins, carbapenems, and monobactams. And so as you all know, cephalosporins, right, first through fifth generations. First, you're going to have your cefazolin, your cephalexin. Second generation, cefotetem, cefuroxime. Third gen, probably the most commonly that everybody knows, ceftriaxone. But here you're also going to have cefotaxime, cefodoxime. These all are the ones that have the X's in them. Fourth gen, cefepime. Fifth gen, ceftaroline. Then your carbapenems, your bigger guns. Carbapenem itself is one. Imipenem, meropenem, a lot of those that, usually require an ID consult. And then your monobactam, estrinanem. And so I kind of put here this penicillin cross-reactivity because we hear a lot, right? If a patient has a penicillin allergy, a lot of times we, say, well, I guess we can't give them, certain cephalosporins, right? Even though it's not exactly penicillin, it's still a beta-lactam. And so I kind of just put here a structure of penicillin versus just the generic cephalosporin structure. The reason why there's some cross-reactivity is because they have similar side chains, specifically that R1 side chain, which if you look, they're exactly identical. And that's usually where you're going to get your cross-reactivity from. The reason why you don't have cross-reactivity with all of the cephalosporins is because once you get through the other generations of cephalosporins, they'll have different side chains. They are not, exactly identical to penicillin. So some with the identical side chains, I kind of put there on the side. So amoxicillin, I won't name all of them, but ampicillin, cephalexin, ceftriaxone, cefepime, cefoxitin, just to name a few, cefpodoxime. And then the bottom there where you see that R2, that's actually identical side chains to the rest of the cephalosporins with the R2 side chains, which is, not exactly relevant to penicillin because we're just looking at the R1. But that's kind of where that comes from. This, you might not be able to read it, but this is just telling us the different grading systems for allergic reactions according to the World Allergy Organization. There's grade 1 through grade 5. For the purposes of this talk, we'll be kind of focusing on grade 1, which is essentially just a very mild singular reaction. So for example, mild, rhinitis, mild pruritus or urticaria may be located or limited to only like one part of the body, maybe just nausea, things like that. Once you get through the higher grades, it's essentially just more side effects in combination and eventually more severe side effects. Grade 5 is like, just the worst outcome, respiratory arrest, cardiac arrest, you're requiring like positive pressure ventilation, anaphylactic shock. That's grade 5. Grade 2, 3, 4 is like now you're getting combinations of things. Like maybe you have more diffuse urticaria, like all over your skin, and you have nausea and vomiting, for example. But for the purposes of our discussion, we'll be talking about and focusing on grade 1. And so this is the title of my article that the poem is based off of, and it's called Amoxicillin Oral Provocation Challenge in a Primary Care Clinic, a Descriptive Analysis. So a little bit of an introduction, kind of how we talked about penicillin allergy is the most commonly reported drug allergy across the world. It is number 1. As I kind of mentioned before, and we talked about when false allergies affect our decisions, we'll often prescribe something that's usually less effective. It's probably going to be more expensive, and it's probably going to be a bit overkill. So, maybe not just killing the gram-positive, strep, for example, that you need to kill, but it's, maybe it also targets like gram-negative and things like that you're going to wipe out that we're not trying to necessarily target. And this is how you develop drug-resistant organisms, how you get things eventually like C. diff. It's difficult for us as PCPs to rule out penicillin allergy. So oftentimes when we need to treat someone with penicillin, we have to refer them to an allergist to undergo that testing. But like I kind of mentioned earlier, it's very difficult because there are so few allergists, far and few between, even just here in San Antonio, but across the world as well. And so there are very, very long wait times to be seen and evaluated by these specialists. I think our skin method. Okay. Methods. So this is a retrospective chart review and also descriptive analysis of cross-sectional data. The participants were patients aged greater than or equal to 18 months who were considered to be low risk for true penicillin allergy, and they deemed this as someone without a history of anaphylaxis or a severe cutaneous reaction, meaning like not someone who said that they got like Stevens-Johnson syndrome or something like that. Someone who did not have a history of IgE-mediated reaction, such as angioedema, bronchospasm, anaphylaxis, and who had never received penicillin before. They were recruited from a family health clinic, and this was in Canada, actually, and it was from November 2017 through October 2019. So they were recruited from this family health clinic, also one ER, and then a preoperative clinic and a dental office. So they were recruited from about like 5 clinical spaces. And their protocol for this OPC was, it was a 2-step, and it was performed by a family med physician and a nurse practitioner. And the dose that they were trying to achieve was in a suspension form for amoxicillin. It was 500 milligrams for patients that weighed more than 10 kilos, or 45 mg per kg for pediatric patients and those who weighed less than 10 kilos. So what they did was they gave 10% of that total dose first. That was like their first like challenge dose. They observed the patient for 20 minutes. If they didn't get a reaction, they gave the remainder of the dose, which is the rest of the 90%. They observed them for 1 hour. And that was it. They did also follow up with the patients after. They had patients submit if they had, delayed reactions and things like that. So what they considered to be a positive reaction was only objective findings. So if someone said, I felt itchy, they did not consider this to be a positive reaction unless they, for example, developed urticaria. Their outcomes that they looked at, the primary outcome was the frequency and type of reaction to the OPC. And then their secondary outcome was also the wait time to complete this OPC. And that meaning the wait time that the patients took to complete the OPC there in that family medicine primary care clinic. The stats that they used, they looked at sample size, percentages, means and standard deviations. They looked at like sex, age, wait time, family history of penicillin allergies, personal history. They calculated interquartile ranges. And they used 95% confidence intervals, and their statistical significance was set at less than 0.05. So these were the results. It wasn't a very long study. This is essentially the only table of results that we have. So it shows that there were 99 individuals in this study that were recruited over this, 2-year period. They were overwhelmingly female. So 73%, which is equivalent to 72 patients, were female compared to only 27% male. The average age was 28.3 plus or minus 21.1. It's very interesting because the standard deviations here are very large in all of the data sets. Actually, I would think probably because our sample size is not too big. It's 99. But we had of the adult patients, 57 of them were adults, 41 were in the pediatric population. The wait time was about 2 months plus or minus 70 days for that OPC to be completed in that primary care clinic. Most people did not report a history of penicillin allergy. And then also most of these people, so 90% of them said that they'd never had a personal reaction before. What they found here, and it's not in the table, but the things that were statistically significant was that there were longer wait times for pediatric patients compared to adults. And of the 99 patients that were in the study, only 3 of them actually had a reaction. So that's equivalent to 3%. They were all pediatric patients and they were all grade 1 reactions, meaning just something very mild. They were all treated with Benadryl and did fine, all of them. They did not find an association between family history of penicillin allergy in children compared to adults. They did not find an interaction between family history and like association with sex and age. And they did not find an association between the wait times between patients that had a history of the allergy versus no history. And they also didn't find an association between the demographic characteristics and the personal history of penicillin allergy. So the way I interpreted this study was there were no reactions in the study more severe than a grade 1. None of them required epinephrine. They all just only required Benadryl and resolved with that. So that suggests that the treatment of at least these complications here in this study are simple. It suggests that it could potentially be safe if you are in the right setting with the right equipment and you have people with the right training to perform RBC in the clinic without an allergist, such as what they did in this study. Anaphylaxis is rare after penicillin OPC in low-risk patients. That's the caveat. And according to the CDC, the risk for severe amoxicillin-mediated anaphylaxis has actually decreased over time and is also extremely rare. So how does the data compare to what's out there? There are a few studies out there. A lot of them are in Canada, interestingly. But in 2016, there was a cohort study that tested, again, the graded OPC, but only in children. Their sample size was much larger, 818. And of those, 5.9% developed reactions. So again, that's compared to the 3% in our much smaller sample size. In 2018, another study was done in Montreal. It was a 5-day amoxicillin challenge, so a little bit longer of the graded OPC. This was also done in just children. Their immediate allergic reaction rate was 2.3%, so a little bit under our 3%. And then in 2019, there was a study done with the Albert Einstein College of Medicine and Johns Hopkins that performed amoxicillin OPC in patients greater than or equal to 7 years old. And there was a 2.6% reaction rate with amoxicillin. So what does this information all mean? Well, the implications for use in primary care, which is the reason why the AAFP has these poems, is, maybe you can suggest that OPC is something potentially accessible and safe to do in the outpatient setting by family medicine practitioners if we have the proper, training and resources. What this will do is downstream reduce the number of referrals that we place to allergists, which might reduce healthcare costs. And then you also cut down on wait times for patients. This also means that we can promote antibiotic stewardship, right? If we're able to remove penicillin allergies that are not true, then we're able to prescribe first-line treatments for our patients and not prescribe antibiotics that are stronger than necessary, which again will decrease, antibiotic resistance. Some limitations and areas for improvement in this study. The sample size, like I talked about, N equals 99, even compared to the other studies, were much larger, 800 plus sample size in the other studies. There was no control group, which I found interesting. The population was heavily skewed towards female. And then again, geographic location, it was done in Canada. But what about other areas, right? So ways that we could potentially improve would be obviously increase the sample size, maybe a double-blind randomized controlled trial, although one could argue that a control itself, if someone has a reaction, could potentially mean that the patient has a reaction to whatever's in that control. So that might, confound things a little bit. Maybe just a meta-analysis of the existing data, because there's actually quite a few studies out there. And then obviously repeating the studies, again, in different locations. This will also allow for different operator variability. Like I said, it was just one family med doc and a nurse practitioner here. But what about other doctors, other, family med doctors, other APPs? What about internal medicine, things like that? So next steps going forward, as clinicians, I think we can probe our patients more about, history of allergies, what type of allergic reaction it is, do they have a family history? And then we can consider if our patients are appropriate for OPC, if we feel like it's going to benefit them. But some of the practical limitations might be, is the site equipped to even do OPC? It takes time. Like I said, you had to keep the patient there, observe them. That obviously requires like a nurse to be there, a provider to be there to administer. That means you're not seeing other patients likely. Do you guys have the proper training? I didn't necessarily see, if there's like a standard like course you can take or anything. There might be, I wasn't able to look at that. And then also, would providers even feel comfortable doing this, right? Because you can say, like, I think this would be safe, I think it's a good option, but ultimately, if you don't feel comfortable, then you're not going to do it. But in that case, then maybe you just send them to an allergist to get this taken care of, once and for all. And then when appropriate, consider removing the medication allergies that you don't think are really true allergies. And these are my references. And I will open it to any questions.
So comment. Well, this actually sounds pretty good. I mean, we all learned that anaphylactic reactions can be fatal. That's true, but as far as penicillin allergies, it is quite rare to have a serious reaction to oral. So the fatal reaction tend to be from medication. So it actually sounds pretty safe.
Yeah. Yeah. And I had never heard of this being done actually. So when I found this article, I thought it was like so interesting because it kind of opened my eyes to everything. And I think this is, could potentially benefit like so many patients. I mean, even on like such a larger scale. But yes.
And just restore.
Right.
Right.
Yes. Exactly. Yeah. Anyone else? All right. Thank you.
Advance with this one. Does want to advance this time to do that. Yes. I put this behind you so you can hear. So that picks up the mic.
Hello, everyone. My name is Marianne. The poem article that I chose for today's presentation is Treat to Target or High Intensity Statin in Patients with Coronary Artery Disease. Here are our objectives for today. So I will be talking about the current lipid management guidelines for secondary ASCVD prevention. And we will also talk about the a randomized clinical trial comparing treat to target and high intensity statin strategies for reducing adverse events in patients with CAD, and also discuss its clinical implications. So background. So historically, specific LDL targets were set, such as less than 100 or even less than 70 for high-risk patients. However, in 2013, guidelines from American College of Cardiology and American Heart Association have moved away from the strict LDL targets and now emphasize high-intensity statin therapy for secondary prevention of ACVD. Now, while high-intensity statins are very effective, patients can be very nervous about starting statin therapy, particularly at high doses. There's also concerns about how people respond to them and their long-term side effects, such as myalgias. And this is where alternative strategies, such as the treat-to-target approach, come into play. And essentially, the treat-to-target strategy allows for physicians to start a moderate intensity statin and upping the dose only as needed to reach a specific LDL goal. This approach allows for a more individualized treatment and also which can enhance patient adherence and reduce side effects from long-term use of high-intensity statins. The Lodestar trial, which is the trial that I will be talking about later, is designed to compare these two strategies, the treat to target and versus high-intensity statin therapy in patients with CAD. This is the 2013 ACC-AHA guidelines in secondary ACVD prevention. So as you can see, high-intensity statin therapy is recommended for most patients with clinical ACVD under the age of 75 unless clinically contraindicated. The goal is to reduce the LDL cholesterol by 50% or more. And for patients that are above 75 or has history of statin intolerance, moderate intensity statin therapy is recommended. The guidelines emphasize that there is no specific LDL target for secondary prevention. Instead, the focus is on statin intensity and achieving the appropriate intensity level of LDL reduction through treatment. This is the 2018 guidelines. It largely reinforced the 2013 recommendations regarding the use of high-intensity statins in high-risk patients with clinical ASCVD. Moderate intensity statins were still recommended for those over 75 or those who cannot tolerate high-intensity statins. The main change was the incorporation of non-statin therapies such as ezetimibe and PCSK9 inhibitors when statins alone were not enough to reduce LDL to acceptable levels, particularly in patients at high risk for recurrent cardiovascular events. While the 2018 guidelines do not strictly require achieving a specific LDL target, they indicate that an LDL level less than 70 is the general threshold where more intensive treatment may be beneficial. So now let's turn our attention to the poem article. As I've mentioned previously, the Lodestar trial aimed to determine whether a treatment strategy targeting LDL levels between 50 and 70 was non-inferior to high-intensity statin therapy in patients with coronary artery disease. The trial is a randomized open-label non-inferiority trial that was conducted at 12 centers in South Korea. Participants were enrolled from September 2016 to November 2019, and they were followed until October 2022. Patients that were included in the study were above 19 years old, and they need to have diagnosis of CAD. The trial excluded pregnant women, patients with contraindication to statins, or patients that were taking medications that could significantly interact with the study drugs or influence lipid levels. In this study, 4,400 adults with CAD were randomly assigned to one of the two statin therapy strategies. So on one hand, you had the treated target group. This is where the statin dosage was adjusted to maintain an LDL level between 50 and 70. And on the other hand, you have the high-intensity statin group. This is where patients receive high-intensity statin therapy with no fixed LDL target. Once they're allocated to a strategy, patients were then randomized to receive either rosuvastatin or atorvastatin. And as shown in the diagram, majority of the patients received the therapy, but some couldn't continue due to adverse events, patient or physician choice, or not following protocol. Both groups had 54 deaths over 36 months, and after accounting for protocol deviations, 2,108 remain in the treated target group, while 2,106 patients remain in the high-intensity statin group. The baseline clinical characteristics of the participants did not differ between the groups. The study population was mostly older male adults with an average age of 65 years old. Both groups had nearly identical medical histories as well. One thing I want to point out is that the LDL levels at the start of the study was also not excessively high, about 86 to 87, and a significant number were already on statins. About 25% were already taking high-intensity statins, and about 57% were on moderate-intensity statins. In the study, moderate-intensity statins were specified as rosuvastatin 10 milligrams or atorvastatin 20 milligrams, while high-intensity statins were defined as rosuvastatin 20 milligrams or atorvastatin 40 milligrams. For the treated target group at randomization, the target LDL was set to be below 70, which was in line with the most recent guidelines at the time of the trial design, which was in August 2015. For statin-naive patients, moderate intensity statin therapy was started. And for patients that were already on statins, the intensity was maintained if their LDL was below 70 and up-titrated if their LDL was 70 or higher. During follow-up, the statin intensity was adjusted as follows. So they were up-titrated for those with LDL above 70. They were maintained the same intensity for those with LDL between 50 and 70, and then down-titrated for those with LDL below 50. In contrast, the high-intensity statin group received fixed high-intensity therapy from the start, and this regimen was maintained throughout the study period, regardless of their LDL levels. I wanted to also point out that non-statin add-on therapies, such as ezetimibe, was not strongly recommended in the treat-the-target group, even if the target LDL was not achieved with high-intensity therapy, and that is to avoid confounding results by introducing other treatments. This ensures that the results reflect the effectiveness of statin therapy alone. Patients were scheduled for follow-up visits at 6 weeks and then 3, 6, 12, 24, and 36 months. Their lipids were also measured at 6 weeks and at 12, 24, and 36 months. If the dose or the type of study medication was changed during follow-up, patients were recommended to return for lab tests within 4 to 6 weeks. Patients were also monitored for adverse effects related to statin therapy by checking their glucose, their liver enzymes, their creatinine, creatinine kinase at 6 weeks and 12, 24, and 36 months. Their A1C was also measured at 12, 24, and 36 months to monitor for potential long-term effects on glucose metabolism. The primary endpoint of this trial focused on major adverse cardiovascular events over a 3-year period, including death, MI, stroke, and coronary vascularization. The secondary endpoint expanded to include a variety of other clinical outcomes such as new onset diabetes, heart failure hospitalizations, and complications like DVT, PE, kidney disease, and cataracts. So now let's talk about the results. So this table tracks how patient statin therapy changed over the study period in the treat to target group. So you can see the statin intensity was up-titrated in 70% of the patients, and most of the increase were from moderate to high-intensity statins. And the highest dose increase happened in the first 3 months and then slowed down over time. Majority of the patients, about 70%, stayed on the same statin intensity throughout the study, which showed that the majority of the patients were well controlled without having to make any adjustments. And about 9% of the patients were down titrated, and most of the reductions were from high to moderate intensity statins. And they were more common early in the study, but also decreased over time. This graph showed the statin use over time in both groups. The orange bar represents the treat the target group, while the blue bar represents the high intensity statin group. The darker the shade of the bars, the higher the intensity of the statin. As you can see in the high-intensity statin group, majority of patients, above 90%, remain on the high-intensity statin throughout the study period. In contrast, in the treat-to-target group, initially about 53% use moderate-intensity statins and 47% use high-intensity statins. But over time, that proportion of high-intensity statin users increased and was about 56% by year 3. This graph showed the ezetimibe use over time. Ezetimibe was primarily used in combination with high-intensity statin therapy to help patients in the treat-to-target group reach the LDL range of 50 to 70. And as shown in the graph, ezetimibe use increased in both groups as time progressed, but it was used more in the treat-to-target group, 20% versus 11% in the high-intensity statin group at 3 years. The lower ezetimibe use in the high-intensity statin group suggests that statin monotherapy was sufficient for most patients in that group. This box plot shows the distribution of LDL levels over time. As you can see, the mean LDL level at 6 weeks was significantly higher in the treat-to-target group than in the high-intensity statin group. But after 6 weeks, that levels did not differ significantly between the two groups. The mean LDL level over the entire study period was also similar between both groups. It was 69.1 in the treated target group and 68.4 in the high-intensity statin group. This table compares the proportion of patients achieving LDL levels below 70 between both groups. At 6 weeks, a significantly higher proportion of patients, the high-intensity group, 61.6%, reached LDL below 70 compared to the treat-to-target group, which was 55.7%. And at 3 months, the high-intensity statin group still had a higher percentage of patients with LDL below 70. And from 6 months onwards, the difference between the two groups decreased and became statistically insignificant, suggesting that while high-intensity statins led to a faster LDL reduction, both treatment strategies achieved comparable long-term LDL control by year 2 to 3 years. This table compares the clinical outcomes between both groups over 3 years. The primary endpoint occurred in 8.1% of patients in the treat-to-target group and 8.7% of patients in the high-intensity statin group. The p-value of less than 0.001 confirms a non-inferiority, meaning that the treat-to-target strategy was just as effective as the high-intensity statin therapy. The death rates were identical in both groups, about 2.5% each. The heart attacks were slightly more frequent in the treated target group, but this was not significant. Stroke was also more frequent in the high-intensity statin group, but again, not significant. And coronary vascularization were almost identical in both groups. The study also found no significant difference in the occurrence of secondary endpoints. And the last thing I want to point out is that while both strategies resulted in similar clinical outcomes, the treat to target strategy was associated with a lower incidence of post-hoc composite secondary events such as new onset diabetes and elevated liver and muscle enzymes, which could be an advantage in terms of long-term safety. So this trial concluded that a treated target LDL strategy was not inferior to high-intensity statin therapy in terms of reducing major cardiovascular events in patients with CAD. This study also demonstrated that a treated target strategy allows for individualized treatment, reducing the use of high-intensity statins for patients who respond well to moderate-intensity therapy. The lower rates of new onset diabetes, kidney disease, and lab abnormalities further highlight a potential safety advantage for the treated target strategy. And one notable finding was that a lower proportion of patients, about 60%, achieve LDL less than 70. And the article mentioned that this is likely due to the low use of combination therapies such as ezetimibe. And several factors may likely have contributed to this. One is that the combination therapy was not recommended in the study protocol because the trial wanted to focus on statin therapy alone. Second, at the beginning of the study in 2016, the combination therapy was less commonly used, but has since then been strongly endorsed based on growing evidence. And lastly, many patients were reluctant to add more medications to their high-intensity statin therapy. While the treated target strategy has potential benefits, several concerns need to be considered. One is that the ideal LDL goal for patients with CAD is still debated, with European guidelines now recommending a more aggressive target of below 55. Second, achieving target LDL levels requires greater effort, as seen in this study, where only about 58 to 61% of the treated target group met their goal. And this is likely due to the low use of non-statin add-on therapy. And lastly, the LDL reduction was initially slower in the treated target group. And again, this is due to the time needed for dose titration. The article mentioned that faster LDL reduction may have been possible if high-intensity statins were used upfront for patients with a baseline LDL above 100, as moderate-intensity statins typically lower LDL by only 30%. This trial also has a lot of several limitations. One is that it's an open label trial, which means that the trial was not blinded, which could have introduced bias. The actual event rates were lower than anticipated, which might have reduced the statistical power of the study. It was also difficult to compare individual clinical outcomes due to the small event numbers. And the trial recruited exclusively patients with CAD, which limits its applicability to patients that are taking statin for primary prevention. And the implementation of the strategy was also not complete. Only around 60% of the patients in the treated target group achieved the target LDL, suggesting that add-on therapies like ezetimibe might be needed more frequently. And lastly, a 3-year follow-up period may be too short to fully assess the long-term benefits or risks of the two strategies. So what does that mean for us as family physicians? So both treat to target and high-intensity statin therapy are valid approaches, but I believe that different patient populations may benefit from one strategy over the other. What's important is that we tailor statin therapy to the specific needs of our patient population. So for us, for our RBG patients who struggle with medication adherence, low health literacy, financial constraints, or transportation barriers, the high-intensity statin approach may be more practical due to its simplicity. It requires fewer follow-up visits and treatment adjustments compared to the treated target strategy. And by using the high-intensity statins, we also reduce the cost, the need for multiple prescriptions, the pharmacy visits, and also repeated LDL measurements to monitor the LDL, making it easier for patients to adhere to their treatment plan. Again, ultimately, I think that the best strategy will depend on each patient's preference, risk factors, and circumstances. Making sure that patients are part of the decision-making process will help achieve better adherence, outcomes, and patient satisfaction. And I've listed here some of the advantages and disadvantages of the both strategies. And these are my reference. And then I'll be taking questions.
study, which statins did they use, or they use all the different ones that you use for prevention?
Let me see. So they used the rosuvastatin and atorvastatin, but I believe when I was looking at the other tables that I have not included here, they've also used pravastatin and simvastatin as well. Any questions? Thank you.